germline's important, not just BRCA, but a panel. And you said that's for the family. Now let's talk about the tumor. You talked about somatic. Should there be other genes in the tumor that we test? I mean, we other genes, germline, we just agreed, but are there other somatic genes that we should test other than somatic BRCA?
Well, to summarize, most studies have just looked at BRCA1 and 2 mutations, be they germline or be they somatic. And there are fewer studies that have looked at all comers, basically platinum-sensitive disease, and that are retrospectively analyzing what are the markers that reflect response to PARP inhibition. And truly, there are other genes that come up, like RAB51C, methylation of the same, PALP2, but small numbers. But in the end, I think if the genes are biologically relevant for breast and ovarian cancer, I believe they're likely going to be predictors.
But we have a molecular signature that includes BRCA-like genes, which are predictive of PARP sensitivity, right? And that's called homologous recombination repair deficiency.
Right.
Do you and that's HRD. Do you test for HRD? You told us you do a panel of germline. Do you do a panel in the tumor, somatic, which essentially would be HRD?
So I think like everyone else, I'm still evolving. So I think what we're moving to is a decision tree where you do a germline test, and those patients who are positive, they're going to get a PARP inhibitor, and you're going to counsel their family or whatever is the appropriate targeted therapy. And those who are negative, in that population of patients, so BRCA wild-type patients, I think we are increasingly thinking that that's a group to look at testing the tissue in and doing one of these assays. And we don't agree on the assay yet, but there's an assay that looks just at loss of heterozygosity as a predictor of response to PARP inhibitors and probably other DNA response agents. And then there's another assay that looks at a combination of 3 tests, including loss of heterozygosity, to try and pick out those patients who at some point in that tumor's journey, that tumor could not fix its DNA well.
So Brett, can I make 2 comments about that?
Yeah, but she had a presentation that showed that basically doing next-gen sequencing, you can get an HRD signature, and there are other actionable mutations. So should we do a panel germline and then next-gen sequencing of the tumor? Is that
well, I think a possible solution would be that at the initial diagnosis, you would do germline testing.
Panel,
And then there is some data that suggests that it's more important to test at the time point of a recurrence. So that would be maybe 2-3 years later when patients suffer a recurrence, that you would then go and do a tissue biopsy, because it would add the information on somatic alterations, and it would add potential changes over time that occurred in the tumor. So that's what I like to do.
Me too. What do you think?
So I agree. I think that we tend to do that anyway. I think the data that we have available is that there's relatively similar findings as long as they haven't been exposed to a PARP. So if you're just looking at chemo pre and post, at least in the aerial trials where we actually looked at the archival specimens and the ones that were done right before the entry onto the trial, they're pretty consistent. So that's good. I mean, it helps us with that. But one thing I wanted to clarify, because I think people get confused about the HRD test and then what you said, the genes that we're testing in HRD, because they're different.
Okay.
So we all know that the HRD process involves a series of proteins at multiple steps, and they have different roles. But they're not all equal.
Yeah.
Some of them, if they're lost, doesn't matter. There's workarounds. So synthetic lethal screens is like very important right now, and it's also identifying those opportunities for us to figure out new ways to not only just PARP, but all kinds of drugs that might have synthetic lethality that takes advantage of mistakes. The other thing is that this loss of heterozygosity gets us away from looking at specific genes.
It's a signature.
Right, it gets us away. It just says, hey, listen, the smoke's there. We figure the fire's probably there. We don't know where it is and exactly how to classify it.
But I like HRD for PARP, but I like these other molecular alterations at the time of recurrence that might inform my next clinical decision, including HRD and PARP.
But Rob makes a good point that if we focus too much on this HRD signature, it doesn't always give you the most accurate reflection, pinpoints to those genes that are relevant, because once you have a genomic scar, there are studies to show that you keep that.
You keep it.
You keep it.
Exactly.
And you can have reversion mutations or other problems, and it misleads you then that you suggest to have sensitivity to a drug that you may not have.
So Matt, you were telling me cell-free DNA at ASCO.
Yeah.
It's an opportunity where you actually it's a liquid biopsy, right? You don't need to stick a needle in. You can tell us what was learned at ASCO from cell-free DNA.
So it's an interesting abstract looking at patients were had plasma and tumor specimens collected at the time of their initial diagnosis and their interval debulking, and they evaluated pathways of interest. It was quite interesting. They actually found more mutations in the cell-free DNA than they actually found in the tumor
Right?
biopsies.
Isn't that because it controls for heterogeneity.
Exactly. So, and it's certainly identifying additional areas of targets are important.
Right.
And I think to your point, when we look at patients that at the time of relapse, a more convenient biopsy may be a liquid biopsy.
Yeah. And they were paired though, and there wasn't a lot of drift, to your point.
Right. So yeah, but I think that I think we still got to go back and think a little bit about what we're getting out of cell-free DNA. So what is it, right? I mean, that's the one question. We know it's DNA fragments that are found in the blood, and we can characterize them, and that's nice. And they're nice because they're dynamic. We can follow a dynamic process, right? You get a cycle of chemotherapy, you can get a blood test. Another cycle of therapy, you can get a blood test. So it does process that. But we need to understand how that relates to tumor biology directly. And I think that's what kind of the point of this was, is that, there is a pretty good overlap. It's not 100%. And then over time, you see this either narrowing of clonality, which might be important. You might see leveraging new mutations. But the point is that we have to also know whether that actually is reflecting the ongoing tumor biology.
But I think we're getting better. I think
Definitely getting
I think
better.
we've clarified the role of germline testing panel. We've clarified somatic BRCA. We'll talk about FDA-approved PARP inhibitor that is approved in somatic BRCA. I think we're understanding the ramifications of an HRD signature, and we're also understanding that there are other targetable genes. So we'll keep learning. You guys will keep working. This is your areas of interest.
Brad, one last thing you mentioned was the Lynch syndrome genes, and
Yeah.
with obviously the MSI positive cancer indication with
love it.
immunotherapy is
Thanks.
quite exciting. So we have now one more thing to look for in our cancer.
Wonderful.
Right.
Although quite rare, one more thing to look for
But
is
wouldn't that be, I mean, it would be exciting to give a patient pembrolizumab on label if you could find a microsatellite unstable patient.
Right.
again, that Lynch syndrome cohort we think would probably be one that we would target.
That's right.
Yeah.
I actually have one that I'm treating, yep.